Hey again everyone, I'm coming at you with another video in between my normally scheduled updates about my ACL recovery journey. This video I'm excited to share. I think it's actually hopefully going to be helpful, and it's something I enjoyed researching and I find this all very interesting. So I am making this video to just lay out, like, once you get an injury, what are your options as far as management. And if you're going to manage it surgically, what are your options for which graft to use to replace your ACL? Now, I want to preface this by saying while I am in medical school, I am not a doctor yet, so none of this is me giving advice or saying what's right and wrong. Like, this is just research I did and I'm sharing with you, but please don't take any of this as me saying what something is that you should do, because that's between you and your doctor, because everyone's situation is so different, and that really can change what is the best type of management for your particular injury. So this is just to give a general rundown of all these options that are available, and then it's really something that I hope you can take this information to your doctor or have it in the back of your head so that it can help you ask questions, have some background knowledge, so that when you have that conversation, you can feel more informed and feel like you can make a good decision with your doctor about what's best for your situation. Just a background of the anatomy of the ACL, which I think helps preface this whole discussion, because you'll know like what's going on and what the consequences of tearing the ACL. So the ACL is a ligament. It's called the anterior cruciate ligament in your knee, and it essentially connects your femur to your tibia. It goes from one to the other in between, and it controls forward motion of your tibia. By the way, tibia is your shin bone. So the ACL kind of stabilizes the tibia, and it doesn't let it slide forward in front of your femur, because that would be not great. So it keeps it stable, and it also prevents a lot of twisting motion of the shin bone of the tibia. So you don't want your thigh bone, your femur, and your tibia going like this. So it keeps everything kind of stable. It also there's something called the PCL, the posterior cruciate ligament, which helps in this as well, but the ACL is more commonly torn and damaged. So you can basically get a full tear of your ACL or a partial tear, and that also affects what management is the best for that situation. So a lot of this, I think I'll be referring to a full tear, but just know that a partial tear can also cause symptoms and needs to be managed, but they're different in a lot of ways. So an interesting fact is that female athletes are like 3 times more likely to tear their ACLs, just because of anatomy, hormones, different factors. If you're a female athlete, just make sure you are very aware of what you're doing and taking precautions to strengthen your leg to prevent this kind of injury. And then when you get an ACL tear or an ACL injury, you can often injure a lot of different areas of your knee that are in close proximity to your ACL. So there's cartilage that's on the bottoms or on the outsides of the bone that kind of like line the knee cavity, so you can damage that cartilage, which cartilage does not grow back, so you want to try not to damage cartilage. And you can also damage your meniscus. You can get tears in different parts of your meniscus. You can also damage the ligaments on the sides of your knee. So the ACL is more centrally in your knee, but on the side you have a medial collateral ligament and a lateral collateral ligament that help stabilize the knee as well. And those can be torn as well. So there can be different levels of injury within your knee, and that's another important factor of how it's managed. So overall, you can manage an ACL tear conservatively, which is non-surgical, or you can manage it with surgery. So you get surgery to fix the ACL, and I'll go through the different conservative versus surgical and kind of what would indicate either one and what they generally are. So for conservative management, that is essentially focusing on physical therapy to strengthen the muscles around your knee to provide stability. In this case, you would not get surgery to fix your ACL, so you would essentially not have a functioning ACL. And since we said the ACL stops like a lot of anterior motion of your shin bone, and it stops this like pivoting instability of a knee, when you manage conservatively without surgery, you just have to make sure you stabilize your knee in other ways, which is the muscles all around it. You're focused on the quad muscles, the hamstring muscles, and you want to really build those up because those stabilize your knee joint. Important to add, when you manage it non-surgically, your knee does remain technically unstable, and you are then vulnerable to other injuries if your knee is in that unstable state. However, this is like a legitimate way to manage an ACL tear, and many people do it. That, again, is something that you would need to talk to your doctor and see what they say, because, like I said, for different situations it would be appropriate, and for other situations it would not be. So that is conservative, non-surgical management. Second option is you can get surgery. So you can get an ACL reconstruction or repair, and it really depends on the severity, degree of injury, how many other things you injured in your knee. And it also depends on your activity level. A lot of people who are really active, athletes, younger people, end up opting for a surgical management just because of their high activity level, and they do need that extra stability in their knee. So that's a popular option for those people. But again, depends on what your doctor says. And there's been studies comparing surgical versus non-surgical management. And I think the gist I got overall is that short term, there might be that question of stability, as far as you'll have an ACL, and if you get it surgically repaired, you'll have one there, it's stable. And if you don't get it repaired, you won't have an ACL there, so inherently it'll be less stable. But long term, it seemed like outcomes were pretty similar, as long as you follow that strict rehabilitation protocol. If you don't get surgery, that's really important. So that's overall surgical versus non-surgical, both viable options. Both can give you like mobility back, but it's just kind of the degree of mobility and what your doctor thinks will be best for your types of activities that you're going to be doing in your life once you recover from this injury. Now, say you decide to get surgery to fix your ACL, you're going to have several options as far as what kind of graft that they use to replace your ACL. And if that's confusing, basically what happens, your ACL looks like say this is your ACL connecting a bone here and a bone here. It breaks in half. So then what can be done is something can be put into that space. There's 2 holes drilled into the bones on either end. They thread a graft through this space, and then it becomes like a string like the ACL, and that stabilizes your knee again. So they can take the graft, this is cool, they can take the graft from another part of your body, because there's tendons in your body that once they're placed in the spot of the ACL, they do something called ligamentize, I believe that's what it's called, and they become like a ligament and do the function of a ligament like that ACL did. Very cool. Your body's very cool. And it just kind of depends where you get the graft from. There's different pros and cons, and then you can also, there's some other extra things you could opt to do that are newer, but I'll explain. So first, I'll start with the quote gold standard of ACL graft, and that is the patellar tendon graft. So your patellar tendon runs over like the front of your knee, and it connects your kneecap to your tibia, which is your shin bone. So when they take this graft, they'll take the inner 1/3, they'll take that out, inner 1/3 of that tendon, and then they'll keep a little piece of bone on the top and the bottom of that graft. Now the bone, they're called bone plugs. When they end up putting that graft in your knee where the ACL goes, the bone plugs at the 2 ends help with the healing and fixation and make it a strong graft once it heals in there. And that's kind of why it's considered the gold standard, because there's been really good outcomes, and it's a strong fixation of the graft within your bones. So this type of graft has been around for a long time, and like I said, it has had good outcomes. People are happy with it. It helps people return to sport, and generally it's just highly recommended. Usually I've gotten the gist from most surgeons. If you're younger, active, if you're a professional athlete or a college athlete, this seems to be the one that's really popular. The downside of this one could be that because of where they take that graft from in the front of your knee, you could get anterior or frontal knee pain when kneeling long term. So you always that's called like donor site morbidity. You'll have some issues at the site where they took the graft from, and that's your patellar tendon. So I've heard of that, and I've heard of some rare, like it can, because you're taking a piece of your kneecap out, because you're taking that little bone plug, that I think can leave the possibility of your kneecap shattering or something happening with your kneecap, but that I think is very rare. So I think overall this one has great results and is very often used. Now, the next one is a hamstring graft. The hamstring tendons, or the hamstring muscle, first of all, is on the back side of your thigh, and they would use one of the tendons. Tendons connect muscle to bone, so they make a little incision actually at the front of your leg, right below your knee, and they take out one of the hamstring tendons, or however many they take out. I don't know the exact number for that, and then they place that in between your tibia and your femur, or your shin bone and your thigh bone, and that acts as an ACL. Similar to the patellar tendon graft that we just talked about, this one has a really good track record. It's been around for a good amount of time, and there's generally good results from it. It's also cosmetically, if that's a concern of yours, it leaves a smaller scar, I believe, than the patellar tendon graft, but I don't know how important that is, just a factoid. And because there's no bone plugs at the end of the graft, the healing takes a little longer. So I think this is why it's not considered the gold standard, and the patellar tendon one is the gold standard, because it takes a little longer to heal. And it also can stretch a little more than the patellar tendon graft over time, and I think that is like a little less stable. So that might be the difference there. But regardless, hamstring graft is still used in athletes, in younger people, active people, but just maybe not people who are in as high risk sports as the patellar tendon people, because it is a little more flexible or stretches a little more. You could be prone to re-injury, but these are all just like, technically these are risks, but I don't think it's very high risk of this stuff. It's not something that would like prevent someone from getting this graft. It's just you have to weigh the benefits and the risks. Okay, next we have the quadricep graft, which is the one that I got actually when I tore my ACL recently. It's relatively newer compared to the patellar tendon graft and the hamstring graft, and so just naturally there's not as much research on it because it's newer. But based on the data that is out there so far, it does seem very promising, and it seems that it may be comparable to the patellar tendon graft, which is that gold standard one, but too early to say that for sure. So that's just people saying what they think might be the case. And some people argue that it is closer, or it mimics more closely the natural ACL. I don't know exactly in what ways, maybe in the strength or the size or thickness or whatever, but that's a good thing that it would be closer to your natural ACL. And it also has less long-term donor site morbidity than the patellar tendon, which has that kneeling pain on the front of your knee long-term. This one is not associated with any major like long-term pain in a specific place, which doesn't mean you can't have pain from it long-term. And some downsides to this one generally are you have increased quad atrophy, so your thigh muscle, the front of your thigh definitely atrophies. That was the case for me. It became very small and weak, and it can take longer to rebuild your quad strength, which you do need to stabilize your knee, so it's important to build it back. You can also get quad tendonitis long-term, which is like inflammation, aggravation of your quad tendon right above your knee, because that's where they take the graft. I don't think I mentioned that before. The quad graft, it's from the quad tendon, which connects the quadricep muscle in the front of your thigh to the top of your kneecap. I will say, because of where that is, there's certain motions when you're recovering that are tricky at first, like straightening your leg when you're sitting and your leg is bent and you try to raise it up straight. That's like all your quad tendon is being used in that motion, and that can be hard at first because they just cut your quad tendon out, so or part of it out, so that can be tricky in the recovery. But in my case, I can say from experience it has definitely gotten better, so I think it's more of an immediate Like your body just has to heal a little bit before you can start doing that kind of stuff. Next option is called an allograft. So the ones I've just discussed, the patellar tendon, the hamstring, the quad tendon, have been autografts. So that means you take the part from your own body and you put it back in your body somewhere else. Allograft means it is a piece from another body. So it's a donated piece from a cadaver or someone who's deceased, and it can be from different parts of the body. It might not be necessarily an ACL that they're just taking from someone else and putting it in, but it could be from the knee, the heel, the Achilles tendon, I think. Maybe, don't quote me on that. Your hamstring, thigh. So it could be anything that they can use as an ACL. There's many different options. And it's obviously like fully sanitized, processed, and then put into your knee. So the good thing about this graft option is that there's no donor site morbidity, as we've been talking about. So there's no place in your body where they had to remove a piece in order to put it where your ACL goes, and therefore you won't have like pain or long-term effects in that area. But because it's from another body, it's considered foreign material to your body, and that can cause the healing to take a little longer. And if it takes a little longer to incorporate and to heal, that leaves it open to re-tearing if you go back to activity too soon. Just overall, it could lead to failure of the graft, but I don't know exactly like how common that is. It's just technically a risk. It's also, I think, commonly used when there's many different ligaments and things torn in your knee at the same time, like if it's complex reconstruction that they have to do, so that they're not taking grafts from all over your body and kind of like butchering up your whole body. They'll take a graft from a cadaver and use that instead. Now, this generally is not used in younger people. I think it's more popular in an older population because of studies that have shown there's better results when it's in older patients compared to younger patients. So I have seen, from what I've seen and read, it seems that younger people generally aren't getting allografts. But again, if that's something you and your doctor decide, then that's what you should base it on. So that is the allograft. Next is a cool new thing that I actually really wanted to do, but I'll explain why I didn't end up doing it. So it's called the Bear procedure, BEAR. And it's a form of like ACL restoration rather than reconstruction, because it is healing your native ACL. So you're not putting anything new in there to act as your ACL. You're taking a torn ACL. So in this case, it has to be a fully torn in half ACL. It can't be like a little tear, so partial tear. It has to be a full tear. And you take those two stumps of your ACL, and there's a little implant that they put in between the two stumps. The implant has your own blood in it, and it's meant to heal the two stumps of your ACL back together, and it just like forms your ACL once again, and it's a healed functioning ACL. Very cool. The only thing is there's certain things that have to be met in order to qualify for this. So it has to be a certain type of tear where the stumps are still like viable and they can be put back together. And the complete tear, you have to confirm on an MRI that it is a complete tear. And you have to be 14 years or older. I found this on their website, 14 years or older. And this is like I said, a very new way of fixing your ACL. And when I was considering it, it was hard to find a location near me that was offering it just as an option of treatment. There were some places that were doing studies where they were like randomized control trials, and you could be potentially placed in a group where you got this sort of repair, but there was no way of knowing that that's the repair you would get, because the other people who didn't get assigned to the Bear procedure would get assigned to the patellar tendon repair. And for multiple reasons that I won't get into now, I didn't want the patellar tendon repair. I, for myself, wanted the quad graft. So I was too nervous that I'd get put in the group of the patellar tendon graft rather than the Bear procedure. So I didn't end up doing it. But I do think it is such a cool option, and I think there's more research obviously to be done for it going forward, and we'll see what that looks like. But a really exciting, like, new potential option. And then lastly, this is not an ACL graft to replace your ACL, but I did want to mention something called an LET stabilization. This is something that I had a hard time finding information about online, and I'll just give you what I know about it and what I've been able to find. So this is something extra they can do when you tear your ACL, and it's essentially like an extra form of stabilization for your knee. So in my case, they gave me a quad graft. They fixed my ACL with the quad graft, and then they fixed my meniscus tear, and then they also did the LAT stabilization. So it's called the lateral extra-articular tenodesis, or iliotibial band, which is the IT band, tenodesis. So it's preventing that anterior or forward motion of the shin bone, as I was talking about, the tibia, or that like rotational motion that you get when you have an unstable knee. So it's stopping the forward and stopping the rotation a little bit more. So I think most often it's used in combination with an ACL repair. So they do it like as an add-on kind of to that surgery. That's what happened with me. I don't know if they do it like on its own just to stabilize the knee. I'm sure maybe they have, but yeah, I would have to look more into that. And what they do is they pass the IT band under the lateral collateral ligament, which is the side ligament that I talked about earlier, stabilizing the knee on the side, on the outside. Pass it under there. They secure it to your thigh bone, which is on top. Your tibia is down here, thigh bone's on top, femur, and it's just above the knee joint. It's attached. So I guess the orientation, it says, mimics that of the ACL graft, and it adds just further strength and stability to the reconstruction. So that was a lot of information. Generally, these different grafts, if you're wondering like rehab time, if it changes for any of them, the rehab protocol changes slightly based on the type of graft you get, because for example, the quad graft, I had part of my quad tendon cut out, so there's certain exercises I can't do for a little bit until that heals, versus someone who got a hamstring graft, their hamstring will have part gone, so they need certain activities that use the hamstring muscle will take a little bit longer to be able to start doing. Generally for all these, return to like sports or high level activity is around like 9 months or more after your surgery. So it's a lengthy recovery for all of them. None of them are like a quick way to like, none of them are shortcuts. They all kind of are in depth, like gonna take a while. I think conservative management, non-surgical, would be maybe take less time recovery because you didn't have like an invasive surgery, but then again, you have less stability, so maybe you couldn't get back to the same sports compared to the surgical repair. All right, so I think that's essentially all that I wanted to go over in this video. And like I said, it was a lot of info. I hope I explained stuff. If there's any questions, leave them in the comments and I'll explain more if I used any jargon that I forgot to explain. But that's the overview of the different management options once you tear your ACL. And one more time, I'm gonna hammer it home. I am not a doctor. I can't give you advice. None of this was me telling you what's good and bad or what you should do. It's just generally what's out there, and this can help you just get a better understanding of what's of this whole injury and what your options are. So thanks for watching. Like I said, I hope this is helpful, and I will maybe make, if I think of any other informational videos, can maybe make some in the future as well. And until then, I will see ya.